So your chief residents a couple months back asked me if I would do a lecture on a topic during your Wednesday conferences, and I said, sure. And then they said, so could you do like back pain? And I'm like, sure. So actually the topic was back pain and joint pain, which is a pretty big topic, I think. And so I kind of whittled it down to pretty much low back pain for a couple of reasons. So I'm going to go ahead and get started here. So it's a common problem. And, I think that all of you that are doing ambulatory clinic, which is everybody, particularly if you're doing med care clinic, you'll rapidly find out that low back pain is something that many patients are coming in for. So it's very, very common. About 12 million people in the CDC Occupational Health Supplement Survey in 2015, about 12 million people reported frequent severe low back pain. That's a prevalence of about 8% of the United States population. So this is really common. I've had back pain twice. It goes away on its own, thank goodness. At least it did for me. And it can come out of nowhere. I was getting ready to see my first patient in the morning about 5 years ago, and I was talking to him, and I went to stand up, and I went over to the exam table, and I pulled his shirt up, and I said, I'm going to have you take a couple of deep breaths, and I kind of flexed a little bit, and it was like, oh! And he looked at me, and he said, are you okay? And I had to have my staff carry me to my car. I mean, it was really bad. So it happens quite frequently. About 8 million people said that their back pain was attributed to work. So work-related low back pain, about 6%, 5.5% of the U.S. population. And about 2/3 of adults will get back pain during their lifetime. I'm an example. Low back pain is the second most common symptom-related visit to primary care practices, only behind upper respiratory tract infections. So that's why I said med care clinic, you tend to see this a lot more. Continuity clinic, they're coming back to see you for their chronic problems, hopefully, that kind of thing. So back pain may not come up as often, but in med care clinic, boy, it comes up a lot. And unfortunately, about 85% of patients, you can't tell them exactly why they have their back pain. I mean, you can't, during your exam, find out the exact cause, or certainly the exact anatomical cause for their back pain. Fortunately, in most patients, it goes away on its own if it's acute low back pain. So just give it time. Typically, it'll go away. It's also quite costly, and this surprised me. So this is a survey, this was actually a study done out of JAMA in 2013 looking at healthcare spending on medical conditions from 1996 to 2013. And the number one was, no surprise, diabetes. $101 billion spent. Interestingly enough, the majority of that money spent on diabetes was for medications. About 60% was medication costs for that. Number two was ischemic heart disease, $88 billion. Some of that was inpatient versus outpatient. So diabetes, a lot of it was outpatient cost. For ischemic heart disease, it's kind of split. You have procedure costs with ischemic heart disease. Number three is low back pain. That's what surprised me. And look how close it is to the amount spent for ischemic heart disease. I mean, it's about the same, $87 billion. So, it's common, and it costs us a lot of money. So with that, let's talk a little bit about when you see the patient with low back pain, comes into the clinic and so forth. So just like any other medical conditions, history is the most important piece of this. So you're going to do your history and your physical exam, but you're going to get most of your clues based on what the patient's story is. So some historical information that is helpful. So you want to know, what's the time course? I mean, is this acute pain? Is this chronic back pain? Because treatments are different depending on the time course of their low back pain. Acute back pain is typically less than 6 weeks. Chronic back pain is more than 3 months duration. And if you have somebody who has prolonged back pain, a lot of times that's associated with more of a chronic pain syndrome. So you start to see more depression symptoms starting to creep in there. Sometimes we see somatization and so forth as well. Age. So what's the age of your patient? Younger patients are more likely to have mechanical back pain, low back strain, disc disease, that type of thing. They also are more likely to have inflammatory spondyloarthropathy as well. Older patients, as you can imagine, are going to have more of those chronic diseases like osteoporosis, perhaps malignancy. So you do see that more likely in an older patient. But the other really common condition we see in older patients is people that have chronic degenerative arthritis in their lumbar spine and chronic disc disease leading to a foraminal or spinal stenosis. So that's pretty common in the older folks. Comorbidities. I kind of alluded to this before. So you want to know, do they have a history of cancers, infectious disease history, they have a history of IV drug use, history of inflammatory arthritis. So if you got a younger person that comes in, they have this history of an inflammatory arthropathy of their knees and hips that's been documented, and they come in with back pain, good likelihood that that back pain may in fact be a process of their inflammatory spondyloarthropathy. Immunosuppression is another risk factor for having some of the non-mechanical causes of back pain. So, they have any history of injuries, falls, so forth, any history of recent surgeries, and what do they do to make the pain better or worse? So I usually ask people, so what makes this pain worse? Doc, it's when I do this or that, or boy, when I cough or sneeze, boy, it shoots right down my leg. So those things would be, for this coughing and sneezing, herniated disc. For an older patient, you can ask them, so when do you get this pain? Well, doc, it's when I get up and I walk. I used to be able to go take my trash out. Now I go down, I come halfway back up the driveway, and I get this pain in my butt. It kind of goes into my upper legs, and it's in my back, and I have to stop or sit down. But interestingly enough, if I use a shopping cart, and I can go, seems like forever without back pain. Well, those are some historical findings that may suggest this person has some lumbar canal stenosis. So let me see here, what else is it? Oh, characteristics of pain. So where is the pain? Does it radiate down the leg, the classic sciatica L4, L5, S1? Goes all the way down the leg to the foot, okay, not just to the knee, but all the way down to the foot. Bilateral sciatica with low pain, with bladder dysfunction, usually urinary retention, you start to think about cauda equina syndrome. If it's associated with a foot drop, so another observational thing, you look at them walk, they flop their foot, that can be an L5 nerve injury, because L5 is what innervates the dorsiflexion of the foot. So I kind of mentioned, and this might be a little small, no, you can see it, different types of low back pain. And in general, the vast majority of low back pain we're going to see is mechanical low back pain. Okay, so things like disc disease, lumbar strain, degenerative arthritis, spondylolisthesis, these kind of things are by far the most common cause of low back pain. Only about 1 to 2% are you going to see the other reasons for low back pain, like infection, metastatic disease, lymphoma, and you can just read them in epidural abscesses. And sometimes we see visceral pain mimicking as back pain too. So the classic one's kidney stones, right? So somebody has, renal colic, they're having back pain. And usually you can kind of tease that out on the history. One that's not listed on this list, I've seen it twice. Probably some of you all doing inpatient work. When you start an older patient on anticoagulation, suddenly has this kind of deep pelvic back pain that just won't go away for anything. And lo and behold, you do a scan and they've got a big psoas hematoma. So I've seen that twice, starting patients on anticoagulation that suddenly had this terrible back pain, and that's really what the cause was. So we've all heard about the red flag symptoms, and these are the findings. So saddle anesthesia, loss of anal sphincter tone, major motor weakness of the lower extremities, fever, vertebral point tenderness, limited range of spinal motion, neurologic findings going on for more than a month. That last one I think is a little soft. I don't think you get all too worried about that, but it's probably going to prompt you to do some other studies. If they still have loss of reflex perhaps and weakness in an extremity that goes on beyond a month, it's probably time to look at that a little more closely. So if you have red flag findings, it may need, the person may need further evaluation, imaging, labs, etc. Key point is, though, is if they don't have red flag findings, it does not necessarily mean they don't have an underlying serious condition. So, if you have somebody who, has a history of, whatever, breast cancer, and they're having new onset back pain, and the fact that they don't have point tenderness or that type of thing doesn't necessarily mean, well, that's probably not going to be metastatic disease. So just be aware of that. A little bit about the anatomy before we go to exam here. So you can see here on the left is the lumbosacral spine, which is where most of this disease originates. And so we always hear about things like spondylolysis, spondylolisthesis, and so forth on these X-ray reports. And essentially, spondylolysis means that the person has fractured a pedicle. Okay, so they fracture the pedicle, and then the vertebrae that pedicle used to be attached to actually becomes anteriorly displaced. Okay, and that's called spondylolisthesis. So now you've got an anterior displacement of that vertebral body. If you can imagine, if you've got the canal like this and one of the vertebrae moves anteriorly, you've, in essence, narrowed your spinal canal, and you've probably pinched off one or the other foramina as well as that vertebrae moves anteriorly. On the right side, that's the kind of the classic herniated disc picture. Usually, typically a younger person, not much in the way of trauma, may have just bent over to pick up something off the floor, gets a sudden onset of radicular back pain. They maybe have herniated their nucleus pulposa, herniates into the canal, may actually block off a foramina. That's usually what causes that unilateral pain, because it just blocks the foramina off, pinches that nerve off through the foramina. And then the bottom vertebrae is what we typically see in patients who are older, who have either foraminal stenosis because of degenerative disease or lumbar spinal stenosis. And you can see they have some, just like what you see with Heberden's and Bouchard's nodes, happens back in the back at the facet joints. And when that bony hypertrophy occurs, there's no place for that to go. It goes into the foramina. Patients start to have radicular symptoms. If they have thickened ligamentum flavum or even bony hypertrophy of the facets, can even go into the canal, cause actual canal stenosis. So physical exam, vital signs, just the typical stuff, particular temperature, person has a fever, then maybe think about more of an infectious etiology. Weight loss, so older persons lost 20 pounds with back pain, I'd be thinking maybe there could be some relationship there between those two things. What do they look like, right? So, watch them walk. Get them up, have them walk. Do they have an antalgic gait, meaning do they favor one side because they're having pain? Do they have foot drop, like we mentioned before? Look at their back. Do they have the normal curvature of their spine, which is lordotic at the neck, kyphotic at the thoracic spine, and lordotic again in the lumbar spine. So is their lumbar spine straight? I mean, do they lose that lordotic curvature? Do they have evidence of maybe asymmetry of the muscles and so forth, which may give you some clues? Do they have a rash? Okay, so we hear about cases. I've actually seen it where people come in with a certain symptom that they said, I've had this pain here for the last week, and I saw so and so, but nobody ever lifted their shirt up, and sure enough, in the back they've got shingles, right? So just take a look at it. Can the patient point to the area of the pain? It can be helpful. Where does it hurt? Have them point to where it hurts and describe it for you. And what's their range of motion? So usually with low back pain, I'll have patients stand up. I'll say, I want you to bend forward, try to touch your toes, just see how far you can go. Should be able to flex about 75 degrees. We saw a patient yesterday in clinic who had back pain. She flexed it to 90 degrees. So, I mean, she had normal range of motion. Hyperextension, which is going back about 20 degrees, is normal. And then lateral flexion from side to side, about 25 to 30 degrees. So you just want to see what's their range of motion of their back. And then you want to palpate. Again, looking for vertebral tenderness. Do they have a fracture? Do they have osteomyelitis? Could there be a malignancy there if they've got vertebral point tenderness? Paraspinal musculature, CVA tenderness, which is usually percussion. We usually put our hand there and bang on it just to take a look, see if they've got any kidney issues. And then if you're considering anything in the abdomen, probably wise if they have a history that suggests that their back pain could be from an intra-abdominal process, it would be a good idea to check their abdomen as well. I mean, do they have a big pulsatile mass there or something like that, as an aneurysm or something like that. So anybody's worked with me in clinic, I tend to carry my reflex hammer with me. And there's a reason for that, because you can get a fair amount of information just by checking the reflexes, the sensory, and the muscle strength of the lower extremities, which can give you some clues, particularly if somebody is having radicular symptoms. So if they're having symptoms that are radiating into the legs, this can be very useful information. So, I mean, you can read it, but I'm just going to go real briefly over it. Ignore the disc herniation part. Just concentrate on the motor, the sensory, and the reflexes. So back in the day, we used to have cotton-tipped applicators that were made of wood, which was fantastic for this. So what you would do is you would pull a little of the cotton off, and there was your light touch, and you'd break the thing, and there was your splinter that did your pinprick sensation, and then you had your reflex hammer to do the reflexes. Nowadays they're plastic; you can't break them. So I usually will take, if I want to do this exam, first off, you got to have the person take their pants off, because you're not going to be able to test sensation unless you do that. And take a wooden tongue blade, try to break it to make your sharps. Just use the cotton-tipped applicator, the cotton piece, and then you'll need a reflex hammer. So testing for hip flexion, have them sit on the exam table, put your hand on their leg, ask them if they can lift their leg up off the table. You're testing hip flexors there. It's L3. Sensory deficit would be the anterior medial thigh, and their patella reflex. If they have a radiculopathy that's causing a radicular nerve to be injured, they should have a decreased reflex of that patella. Okay, so remember, so if it's an increased reflex, then they have myelopathy, right? That would be a central problem, something wrong with their spinal cord. Knee extension, having them sit again, have them see if they can kick out against resistance to you. That's L4. Anterior leg, medial foot, loss of sensation. Again, patella reflex is involved with that as well. L5, that's your dorsiflexion. So different ways you can test dorsiflexion. You can try to have them walk on their heels. I typically just keep them on the exam table, and I ask them to just point their toes up toward the ceiling and keep them up there. And I try to test resistance of not only their great toes, but also the whole foot. L5, again, the sensory deficit. I mean, we used to have one of those dermatome things in the clinic, but again, lateral leg, dorsal foot would be the sensory loss there. I've never done a medial hamstring reflex, so I presume you whack the medial hamstring and see if their leg goes up, but I've never done it. And then plantar flexion, which is S1, and plantar flexion, that's walk on the toes, but again, I usually just have them stay on the exam table, and I tell them push down like you're pressing on the gas pedal with both feet, and push as hard as you can, and then try to see what their strength is to plantar flexion. Posterior lower leg, lateral foot, and then that's where the Achilles tendon reflex comes into play. People will have deficits in their Achilles tendon reflex with an S1 nerve root problem. So if you think they have cauda equina, then you need to check their anal and sphincter tone. S1 is that area, and they will lose their anal and sphincter tone. They'll have saddle anesthesia. It's in the perirectal, genital, upper inner thighs. Normally, people should be able to differentiate between pinprick and light touch in that area. They lose that sensation. If you happen to have a bladder scanner, it can be helpful to see if they have an increased PVR, because a neurogenic bladder is also involved with Cauda-Equina syndrome quite commonly. So you'd want to check that as well. The other maneuver that we commonly do in the clinic, but really it's for people that give you a history of radicular pain. So if somebody's got pain going down one or both legs, it's helpful to do a straight leg test. And there's a way to do this. So you want to have the person lay supine on the exam table, let them just get really relaxed, cup your hand under their heel. I usually rest my other hand on top of their thigh close to their knee to keep them from bending their knee, because you want to lift the whole leg up as a unit. And they should get, if they have symptoms, when you elevate the affected leg, they should get pain that mimics their pain somewhere between 30 to 60 degrees of elevation. And that pain needs to be radiating below the knee, okay? So commonly we get people, we do the straight leg raise and we lift it and we get to 10 degrees and they're writhing in pain and so forth. That is not something that is consistent with a radicular pain, okay? It should be below the knee at an angle at the hip of about 30 to 60 degrees. That test is kind of fairly sensitive, 75 to 90%. So a negative test, if they don't have that, then you can pretty much tell them that it's unlikely that they have a problem with the pinched nerve back there. But if it's positive, then we can do something called a crossed straight leg test. And essentially what you do is the same thing on the other leg. And if they get symptoms in the affected leg, like they had when you lifted the affected leg, that's a pretty specific test. So if they're positive on the affected leg and you lift the other leg and they still get symptoms on the affected leg, it's 85 to 95% specific. So, you know, if they have that, it does help rule in nerve root irritation. Piriformis syndrome. I mean, I think that, you know, last year it seemed like I was seeing that diagnosis a fair amount, piriformis syndrome, and I'd never really seen it in my clinic very much. It's not that common. Mostly it's in middle-aged people or younger people. So it's thought to be from the piriformis muscle, and it's the irritation of the sciatic nerve as it either goes through, so it commonly pierces the piriformis muscle, but sometimes it goes around the piriformis. The piriformis muscle attaches to the inner part of the sacrum, and then it attaches to the superior medial aspect of the greater trochanter. So you can imagine it kind of goes from the inside of your sacrum to kind of the upper middle part of your greater trochanter. So when it contracts, it actually internally rotates your hip. Okay, that's what it does. It does a little flexion, but it's mostly internal rotation. Usually people will have pain that's deep in their pelvis, in the sacral region, maybe radiates into the buttock, sometimes the proximal thigh. Rarely will people get numbness in their foot because that sciatic nerve is being irritated. There's something called a piriformis sign, and essentially you lay the person on the table, let them relax, and the affected leg will actually, in the relaxed position, will be externally rotated. Okay, so we tend to think of that when we see, or when you're doing inpatient stuff and somebody has a hip fracture, right? So, and my thought was, well, if this thing's an internal rotator, why is it that their leg would be externally rotated at rest? Well, the thought is that what actually happens is that piriformis muscle is tight, and instead of internally rotating the leg at rest, it actually pulls the sacrum over a bit. And so when the person's laying flat, their whole pelvis is tipped over, and their affected leg actually externally rotates. So the piriformis sign is that it'll be externally rotated, and one of the things that you can do to see if that actually is possibly piriformis syndrome is to take that leg while it's still in a relaxed position and try to internally rotate it past 90 degrees. Okay, so rotate it toward the other leg. And people may get mimicking pain deep in their pelvis and sacrum again, which maybe give you a clue that they have piriformis syndrome. But again, not that common. So the question always is to image or not to image? And I can tell you that almost every patient that comes in with acute back pain does not need imaging. Not lumbosacral spine films, not an MRI, not a CT, nothing. If they have red flag symptoms and findings, that may change your mind. Okay, so those conditions are a little different. But the person who comes in with no red flag symptoms or findings, they don't need imaging. That's supported by every major guideline on the evaluation of low back pain. There's not one that says, yep, start right off with an X-ray. We don't do that. It hasn't been shown to be of help. Other indications, neurological findings that persist longer than 4 to 6 weeks. So obviously I have to have the person come back. If they still have that loss of reflex and leg weakness, I get an image. And if the person has failed physical therapy and you're thinking maybe this person's going to need to have some caudal injections, they're going to have to see a specialist, maybe have some type of intervention, I usually will go ahead and order the X-ray or typically the MRI scan. Because a lot of times the consultant, I mean, it saves them a trip to see the consultant, and the consultant says, well, we need to get an MRI scan, then we'll have you come back in 6 weeks and give you your shot. You know, they could have the MRI scan done already. You know, you're probably going to be going that route anyways if they've already failed physical therapy. So that would be an indication for me to do that. I think this is the blurry slide. Yeah, sorry, I tried my best. It's probably something when you don't give credit for the slide, it automatically gets blurred. So. But this is just this is actually a review of some studies looking at MRI findings in asymptomatic patients. So these are volunteers, and they said, hey, let's get an MRI scan of your lumbar spine. It's free, and let's see what you got. And if you look at that, the prevalence of having a significant finding is anywhere from 20%, 22% to 90%. Of having an abnormal MRI scan in someone who's completely asymptomatic. So just another reason to kind of be prudent with your imaging studies, because you can really lead you down the wrong path if you're not clinically thinking of a condition. One thing before I talk about treatment, just on, we see a fair amount of this, malingering, right? So people are coming in and you're like, I don't know why this person has back pain. I can't figure out anything that's going on with this. And so there's been there's the Waddell sign, which is, hypersensitivity to touch. So, you kind of just rest your hand on their back and they're writhing in pain. There's something called, and actually there's a Waddell's point system actually, where you do these different maneuvers to try to see if somebody's malingering and so forth. And then there's something called a flip test, which I've done before, where somebody's has this positive leg raise, but it doesn't seem like it's really that positive. So maybe they get this writhing pain and I'm at 10 degrees or something like that. So instead of putting the leg extension in and having them sit up with their lower leg flexed, keep the leg extension out and help them say, I'm going to help you sit back up here, and you let them sit up, and now they're sitting at a 90-degree angle, right? You've done a straight leg raise to 90 degrees, and they're not having any pain. That's called a flip test. Just got to be cautious with these, though, because just because they have a positive Waddell sign or a positive flip test, you should not just go, okay, fine, this is just malingering. We're not going to do any more studies or anything else about this. But I mean, I think that some of those are real easy to, it just kind of gives you a feeling as to, is this really real or is this not real? But be cautious with that. So, treatment options for low back pain. So, fortunately, we actually have a clinical guidelines pathway in EPIC. Okay, so I sit on the CPG committee, and I didn't do this. I wasn't involved in this particular pathway. But if you go to the EPIC, if you go to the provider dashboard, does everybody know where the provider dashboard is? You got your schedule and you got your messages, and then there's this thing that looks like a little bar graph, I think. And you click that, and there's this provider dashboard, and right in the middle we have these things called clinical pathway guidelines. And so one of them is low back pain, a clinical back pain guideline. It has a lot of useful information and so forth in it. So we got one for diabetes and for heart disease, and there's more coming as we go on. So this comes right from that guideline. Okay, so it's all in there. So pharmacological therapy, acetaminophen, low quality evidence, probably less effective than NSAIDs. My personal experience doesn't usually work very well for low back pain to give them acetaminophen. NSAIDs, there's moderate quality evidence, better than placebo. Of course, you got to pick the right person. Somebody who can't take NSAIDs, that's not somebody you want to give it to. IM Toradol ×1 in the office is helpful, and you can do that if it's someone who can take an NSAID. Steroids, low quality evidence. Interestingly enough, from an anecdotal experience, if somebody's having radicular symptoms that are acute, I think giving them either a burst or a taper of prednisone or your Solumedrol or whichever, or Medrol dose pack or whatever, can be helpful. And in fact, the second time that I had back pain, I've only had it twice. Second time, I actually got prednisone, and it was gone in like 2 days, whereas the first time it was gone in like 4 days. So, from my own personal experience, it seems to work. Opiates, moderate quality evidence that for short-term pain relief. There's no evidence that opiates work for long-term pain relief in patients with chronic back pain, or that they increase function in any way, particularly as the person goes into the long-term back pain. Muscle relaxants. So this has been helpful. Got to be a little bit careful. Wouldn't use Flexeril. Cyclobenzaprine in elderly has anticholinergic effects. Tizanidine, which is the one I typically use, can cause transient lowering of blood pressure, so you got to be a little careful there. Somebody's kind of running on the low side anyways. You might want to think maybe not to give them that. And we typically avoid carisoprodol, which is soma, dependency issues. So I don't normally use that one at all. And I've also found that methocarbamol, Robaxin, I haven't found that to be very effective either, but we typically underdose that. If you look at the package insert, you look at the dosing for Robaxin or methocarbamol, we typically give 500 TID. Well, it's like 1,000 TID if you look at how much you're supposed to give. But it does seem to work for acute pain in the first week, so it's reasonable to do that. In the past, people have given benzodiazepines for kind of muscle relaxation. There's no evidence that that does anything for low back pain. So, but then there's a bunch of non-pharmacological therapies too. And I took this table out of that guideline, but things like Tai Chi and yoga and so forth. Some of these can be helpful, not great quality evidence, but it's something that you can advise. Two of them that do appear to be helpful. One is heat. Okay, just having them use a heating pad or heat therapy seems to work. And the other one's massage therapy. So people that can get having acute back pain, if they have the ability to go get a deep muscle massage, it can actually give them some short-term relief. So my approach to low back pain is start off with pharmacological treatment if I can, and wait 2 to 4 weeks. And most of these people should be better. Okay, if they're not, that's my trigger to kind of pull to go to physical therapy. So if they're not getting better, I tell them right off the bat when I see them the first time, look, if you're not better in a couple of 3-4 weeks, then contact me, and as long as it's the same and hasn't worsened or you haven't developed something new, I'm going to send you to physical therapy, and that's what I typically do. And we let them go through physical therapy, and if they fail physical therapy, that's when I will suggest that we need to get some imaging studies here. Probably going to need to have you referred to somebody else to see if they can do some other modalities to make your back pain go away. If there's any concerns about neurological deficits, I will have those patients come back sometimes because, again, I want to make sure that whatever their neurological deficit was, it's gone. Make sure they haven't gotten a new one, something like that. So what about chronic back pain? So we see a lot of chronic back pain here. And medications, as you probably have all found in the clinic, medicines don't work very well for chronic back pain. It usually requires a multidisciplinary approach. So fortunately now we have something, I think it's called the Pain and Wellness Center or something like that. But essentially it involves pain management specialists, physical medicine specialists, psychologists, acupuncturists, social workers. There's a multidisciplinary group. It's a comprehensive pain center. And the reason is because chronic back pain is really a chronic pain syndrome, and and there are so many other comorbidities that have come along because of this chronic pain that giving them a medicine for their pain is not going to make it go away. And the focus really then becomes more palliation and patient education. Telling the patient that their pain may not completely go away, but there's hope, and they can continue on with their lives, and it shouldn't be the dominant player in their life. So unexplained chronic low back pain is commonly associated, just like I mentioned, mental health disorders, work-related issues, litigation, drug-seeking behavior, and so forth. So if you can't find out why they have chronic back pain, they've had back pain for a year, and they're coming in again, and nothing has helped, and chances are medicine's not going to help that. There's maybe something else going on there that's precipitating or causing this persistence in their symptoms. So what about gabapentinoids? It's kind of our go-to drug for back pain. First off, it doesn't seem to work for acute back pain. Okay, so we'd be talking more about chronic back pain. We use it a lot. So what's the data show? So in 2017, this is a table. They're looking at random. It's a meta-analysis of RCT trials, and just to see the effectiveness of gabapentin and pregabalin. And if you can see the unity here, so gabapentin compared to placebo doesn't seem to do very much for chronic low back pain. Pregabalin alone compared to the active analgesic controls, they gave people actual analgesia, maybe a little bit better. Pain relief, the success, what's the chances of success of getting rid of their chronic low back pain with gabapentin versus placebo? It's at unity. It doesn't do anything. And the success with pregabalin alone compared to an active analgesic, there's no, the success of making their low back pain go away, even compared to an analgesic, it crosses unity. So, even though we use this a lot, there's not very much evidence in chronic low back pain that the medicine's actually effective. It can be effective in other neurological conditions, so commonly post-herpetic neuralgia. Pregabalin works well for failed low back surgery syndromes. So people that have had low back surgery for radicular back pain and it failed, there's some evidence that the gabapentinoids can be helpful in that condition, but not when they come in just with chronic low back pain. There was another study done by the VA the year before. Not very many people in this study. 55 got gabapentin, 53 got placebo. They forced the titration to 3,600 milligrams a day, so they weren't using little doses. They moved the dose right up. And what they found is that both groups got pain relief at 12 weeks, and there were no differences between the groups. And so, there's all the different numbers, but you can see the red and blue line. They just paralleled each other, and both of them got better after 12 weeks. But there was no improvement when you gave the person gabapentin. It didn't separate the lines there. This is a slide, essentially, we tend to give gabapentin. We don't think too much about it causing side effects. These medicines are associated with a significant side effect profile, particularly in older patients. So confusion, dizziness, fluid retention all occur. And you can see, it can be upwards of 28, 25% of patients can get one of those side effects from a gabapentinoid. So, I know we use it, but there's not a lot of evidence to suggest it works great for chronic low back pain, and it's not without potential side effects. So, not that you shouldn't use it, but think before you prescribe it. And if they're having chronic back pain, you might want to consider seeing if they can get into some type of comprehensive pain management program, which would be more effective. So with that quick overview, I do have one case. And so I couldn't figure out how to do these things where I could press a button and make the result go up. So what I'm going to do is I'm just going to go ahead and just give you the case, and then I'm just going to just throw it out there and say, so, what would you like to get, or what would you like to ask? And remember, history, exam, studies, okay? So a 62-year-old man comes to your office, he has low back pain. Okay, that's all I'm giving you, low back pain. So, what kind of historical information would you like to know? It's been going on for about 2 weeks. How did it start? Well, it started about 2 weeks ago, and just in my low back. Just wasn't really doing anything. No, it's pretty much the same. I've taken some over-the-counter. I took some ibuprofen or something, and you know what? It gave me a little bit of relief. It doesn't radiate. It's just staying like right here. So, well, not really. I've laid down, and it doesn't seem to get better when I lay down. I can walk. It doesn't seem to bother me when I walk. It's just kind of there all the time. Haven't had any weakness. Nope. Been able to go to the bathroom fine. Well, you know what? You looked at his record and you saw that he's lost about 3 pounds in the last 6 months. What's that? Nope, it's the same. No, it's pretty much the same. I didn't fall off any ladders, so I didn't injure myself or anything like that. 2 weeks ago, I had a prostate biopsy. My PSA was up. No. So here you got a 62-year-old man who's got non-radiating low back pain. Nobody asked if he had fevers, but he didn't check his temperature, but he's felt chilled sometimes, he thinks. Occasionally he'll feel a little chilly. Nobody else at home does. He might wrap himself up in a blanket. Had a prostate biopsy 2 weeks ago. No injuries. What physical exam findings would you like to know? No, the biopsy result's not back. It was just 2 weeks ago. It's an institution. They take a long time. But it was positive. So a physical exam, anybody want to have any questions I can answer? His rectal tone, you know, it didn't check the rectal tone. He does have some mild point tenderness. Yeah, he has some mild point tenderness kind of around the L3 level, right at the midline. I'm sorry? Step-offs? No step-offs. Nothing like that. His temperature is about 37.1 C. So not particularly, not too bad. Yep. His reflexes are, his patellar and Achilles reflexes are 2+ bilaterally. Strength normal. Sensation, light touch, and pinpricks normal. Range of motion of his back is fine, but he's kind of tender, and everywhere you move him, he's sore. Abdominal exams unremarkable. No bruise, no masses. Normal alignment. I mean, he doesn't like having the back pain, but he's okay. So this, he doesn't have any skin changes at all. So here you have this guy, 62 years old, got this non-radiating back pain, doesn't have any fevers, but he's had some chills. He had a prostate biopsy 2 weeks ago that you now know he's got an elevated PSA, right? Or he's got prostate cancer. So what lab results? What lab results do you want to know? So because you presume this guy's got some red flag findings, right? So I mean, he's got a couple things that you'd probably say, maybe we should get some labs and imaging on this guy, right? I'm sorry? We didn't check his LFTs. So his CBC, is hemoglobin's 13.1, hematocrit's 39, white blood cell count's 9,100, does have neutrophilia, 84% neutrophils. Calcium's normal, by the way, whoever asked that, calcium is normal. Anybody want to know what his PSA was before the biopsy? 7.1. Okay, so it wasn't, 70. Okay, so 7.1, just, had the biopsy because of that. Any other labs? Alk Phos. Alk Phos is normal. UA, good. Yeah, he has about 3 to 5 RBCs per high-powered field. Otherwise, it was normal. ESR, 36. 322. So his ESR is not significant, right? He's 62 years old. But he's got a pretty high CRP. Any labs you want to do while he's sitting in your office right now? Or at least get them drawn anyway? Clue? What's that? You're right. Did you say blood cultures? I would do blood cultures. Yeah, I think it's a good idea. So, how about any imaging? What would you guys like to get for imaging? X-ray. So lumbar sacral spine film. It's got osteophytes, L3, L4, L4, L5. Has some spondylolisthesis, like we mentioned before, of L3, a little bit of anterior displacement. He has calcification of the aorta, but it's not dilated. Just you see calcium in the aorta. Any other images? No lytic lesions seen on the LS spine film. How about a CT scan? So CT of the LS spine shows osteophytes, L3, L4, mild to moderate foraminal stenosis with osteophytes at L4, L5, bilateral moderate bilaminar foraminal stenosis, and calcifications of the abdominal aorta. Pretty much the same thing that you saw on the LS spine film. Yeah, MRI. So he has a high signal intensity at the L2, L3 disc with the destruction of the vertebral end plates of L2 and L3, and a high signal intensity marrow edema of L2 and L3. What does this guy have? I'm sorry? No, he does not have metastatic disease, because you should have seen something on the other X-rays for metastatic disease. And a PSA of 7 is unlikely to be metastatic bone disease. It's usually much, much higher than that. So no, it doesn't have a hematoma. You should have, you probably would have seen that on the MRI scan if he had a hematoma. So one of the key points here is, so what you do is, so you're going to admit this guy with vertebral osteomyelitis, okay? CT scans and lumbosacral spine films are notoriously poor for picking up vertebral osteomyelitis. That is an indication to get an MRI scan. MRI scan shows marrow edema, end plate destruction, high signal intensity lesions. So you'd want to get an MRI scan. You got the blood cultures. They came back growing beta-lactamase producing E. coli susceptible to fluoroquinolones. He was on antibiotics for a couple of days. These were uropathogens, probably at the time of his prostate biopsy. And since they're sensitive to fluoroquinolones, if he's doing well, you could have him on IV antibiotics for a fairly short period of time. Could probably switch him over to oral antibiotics at that point and send him home. So that's it. Any questions? All right. Great. Thanks a lot.